Hello, everyone. Welcome back to Beyond Type 2. I'm Tiara, and I'm the Senior Project Manager of Beyond Type 2. Beyond Type 2 has a bunch of resources for people with type 2 diabetes to live their best lives. And today I'm joined by Eugenia Gianos. She is the director of the Women's Heart Health Program at Lenox Hill Hospital and the director of Cardiovascular Prevention for Northwell Health. And if you can tell by her title, today's topic is about cardiovascular risk and its connection to type 2 diabetes. I'm so excited to chat about this discussion or chat about this topic because the risks of developing heart disease or any type of cardiovascular disease are higher if you have diabetes. So I'm excited to bring this awareness to you, and I hope that you can take away some really great points from our discussion. And now I'm going to introduce my guest, Eugenia. Eugenia, please introduce yourself to our audience.
Great. I am a cardiologist in New York City. And as Tara mentioned, I'm running a number of programs that tie in very much to this topic. And I told Tara earlier that one of my confessions is that as a cardiologist early on, the way we were trained, we avoided taking care of diabetes. But it is a whole new world. We realize how important this is for our diabetes patients and how crucial cardiovascular disease prevention is for diabetic patients, that we actually are now managing the diabetes, taking care of the whole picture. And I think this is a wonderful forum for what we really want to do is make sure patients have all of the information they need to make these decisions.
Yes, yes, exactly. And that's kind of like something we were just talking about right before, which is it's important for patients to get the information and then they can of course decide what they want to do with their healthcare, but that education is so important, that awareness is important. So let's kind of dive into your background a bit and what inspired you to get into cardiology?
Sure. Most physicians tend to take little curves in their careers. And I think, myself included, I went into medical school thinking I'd be a pediatrician. Then I realized I was fascinated by adult medicine and talking to people and really learning about the story behind their disease process. And I was really attracted to cardiology because of the excitement and the procedures and all of the invasive interventional type things. But ironically, as I continued to go into cardiology, I realized that I was even more passionate about the preventive part of it. So, I've shifted gears to some extent. I still take care of very sick, very complex cardiology patients, but now we're focusing on the whole picture and making sure that we are addressing, prevention as well as any intervention that's needed.
Excellent. And how often do you encounter patients with type 2 diabetes? And when they're referred to you, are those referrals more likely to come from a specialist, like such as an endocrinologist or a primary care physician?
I see them very often. The reality is that, when especially we work a lot with trainees and they will present cases to us, from the hospital or in our practice. And the reality is that every time we hear a presentation of somebody with heart disease, it's, 47-year-old with high blood pressure, high cholesterol, diabetes, now presenting with heart disease. It's like these things tend to go together, unfortunately. So, one of the most important things to keep in mind is that diabetic patients, the thing that is going to affect them most in their lifetime is cardiovascular disease. And as a matter of fact, for a 50-year-old who has diabetes, their life expectancy is 6 years shorter than the average individual because of that. Now, having said that, not of course if you address the important issues and you keep the sugars under control and you get them on the right therapies and lifestyle. But this is a common thing that we're seeing, and we get referrals from pretty much everywhere, I would say. But most important is we try to partner with their other practitioners so that we're not assuming someone else is taking care of a certain aspect, but we're all really working together to optimize every aspect of the patient's care.
Oh, that's great. Because that was definitely going to be a question I was going to ask you later, which is if you are connected with their other doctors. One thing that I was talking to with some other professionals was some patients are sort of siloed in their care. Like they may talk to their primary care physician, but their primary care physician may not talk
Yes.
to their cardiologist. And can you explain like sort of the importance of having different professionals connected
Yeah.
for one patient.
That is so essential. As a matter of fact, I'm working with a patient right now that I don't feel like we're doing her justice by, having a one practitioner in Queens that uses one electronic medical record, another one in Brooklyn, and another one in the city, and everyone being on different pages. And so I think one thing that helps is if you're in one health system and you keep your care in one electronic medical record also, so that those doctors can see the other notes, they can see your most recent testing, your lab values. And if that's not the case, because sometimes you do need to use an expert from, outside of a particular place, then you need to take it upon you to make sure you bring or you help to get, the last labs that you had with your doctor or your testing. Unfortunately, patients come in and they say, oh, no, 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 I saw a doctor 3 months ago and everything was okay. But for me, I don't know what that means. Like, what did they check? Did they think to look at all of the numbers? Did they also do, different testing? So really, I think you're right. The communication and our healthcare system is not perfect. I hate to
Yeah.
break it to people out there. We definitely, communication is hard. I think, we're working very hard as clinicians to work on those barriers. And like, do we just send a message every time we start a new medication, send them back to their other doctor? We're trying to improve those communication systems, but I think as a patient, you want to also advocate for yourself.
Absolutely. And we're starting to see changes in how we communicate with our multiple providers, like with things like My Health or My Chart, where you can pull up all your past labs, you can see your entire care team. So it's great to see progress being made, but of course, like it can always improve.
Yeah.
And when you meet a type 2 patient for the first time, what are some of the key things that you try to go over with them, and especially when it comes to cardiovascular disease?
Sure. We actually have created a lot of handouts and we're creating more. I would say, one of the handouts that we have is just about cardiovascular prevention in general. And it has and I can share this with you, it's an illustration in an artery of a little bit of plaque in the wall. And then what happens if a little bit of the plaque that sits in the wall were to break off or rupture and all of your clotting factors kind of come and stick in the platelets. And that's essentially what causes a heart attack or a stroke. So very simply on this one handout, we have the risk factors for developing heart disease and where you would want your numbers to be for your sugar, your blood pressure, your cholesterol, your weight, not smoking, of course, diet and exercise. So we try to explain, one important thing is that if you can get all those numbers optimized in your lifestyle, then the chances of a heart attack and stroke are very low, if you really work with your doctor. So that's the main education piece I think that we try to start with every patient, diabetic or not, because that's the most common cause of death in the world.
Yeah, and I think having that visualization is probably super important for the patient. Do you ever, or I guess, what are some misconceptions that you hear about heart disease from some of your patients, your type 2 patients?
Sure. I think that even as clinicians, we had misconceptions about the disease
Mhm.
process years before. We kind of imagine that the disease process is just that you have this tube and then you get 20% narrowing, 50%, 60, 70, until you get to 100. And that's how the process happens. The truth is that, all of this small amounts of plaque that you have in the arteries is present in the whole body, not just, let's say, in the heart, but it could be in the neck arteries, in the legs, etc. And you have small amounts in different places that you really want to sort of heal over and stabilize, almost like a scab, kind of cause it to heal. Because really, even that 30% narrowing in the artery, if that were to rupture, that can actually cause a heart attack.
Wow.
Yeah, but we can stay. The good thing is that there's very good, evidence as to how we can stabilize that by decreasing inflammation, lowering your cholesterol, getting your sugars under control. So it's in some ways, it's more scary to know that you have this plaque everywhere, and even the 30% stuff is, putting you at risk. But the good thing is that all of the things that we have to improve your risk take care of the whole body to really quiet this down.
Yeah, and Eugenia, there's actually a question that just popped up in my mind. It's not on the list that I gave you, but I when you're talking to patients who show those risks, how do you advise them? We know that like blood glucose control is always important, but like in terms of like real world effects like exercise or food, what are some strategies that you recommend? Is it safe to do cardiovascular or resistance training even with those higher risks?
Yeah, I think sometimes what happens is that, to be conservative and safe, patients are told not to do, significant exercise because, God forbid something were to happen.
Yeah.
The truth is that exercise has so many benefits that, in all likelihood, almost every patient will be able to get to a point of full exercise. What is important, though, is that every patient be screened to make sure they're okay. So,
Right.
sometimes patients will tell me, look, I'm running an hour a day and at good speed and I have no symptoms, then that patient is probably just set and they're probably not going to need elaborate testing to decide whether they need to do they are able to do exercise. But for somebody who's very sedentary and really doesn't even walk much or take the stairs, then we might want to assess if it's safe. Do they have any narrowings that are decreasing blood flow in the heart that would put them at risk?
Mhm.
And optimizing all those other factors that we talked about sometimes even before they start exercise can also be helpful. But from my standpoint, exercise is important, and starting slowly and gradually building up is really the way to do it safely. That's the most important thing that you can do.
Yeah, and we've covered that on Beyond Type 2, like, especially for people who aren't used to exercising, maybe even just going for a walk, and kind of
Yeah,
doing that and remaining consistent, and that's, also something we preach is, like, consistency is really the key when building some of these newer habits. Um,
yeah,
and
yeah.
and I guess let's talk a bit about medications. We kind of chatted about that beforehand, and just, like, the benefits that we're seeing now. You mentioned earlier that traditionally cardiologists will stay away from diabetes, but because we have these new medications such as GLP-1s and SGLT2s that show cardiovascular benefit, what changes are you seeing in your field and among your colleagues? Are they excited to work with diabetes patients and kind of introduce these new therapies?
Yes. So here at Northwell, we realize how important this is and are now putting forth an initiative to get all of the practitioners more comfortable in using these medications. So, and that includes cardiologists, endocrinologists, internists, and nephrologists, kidney docs to begin with. Amongst all of our professionals, the ones most excited about this class of medication is the nephrologist because they're finally seeing a new class of medication that has benefits for the kidneys. But as cardiologists, we are extremely excited also because, historically, a number of the other medicines actually had negative effects to some extent. They were unavoidable, but, with insulin or things like sulfonylureas, you may have some weight gain, increased appetite, hypoglycemia, or drops in your sugar levels, which obviously have a negative sort of effect. And they didn't necessarily improve your risk of having heart disease or stroke.
Mm.
Whereas now, with the SGLT2 inhibitors and the GLP-1 agonists, we have drugs that reduce cardiovascular disease risk. The SGLT2s reduce kidney risk and heart failure risk. The GLP-1s also cause weight loss. As a matter of fact, they're used in non-diabetic patients also to cause weight loss. So yes, we're all very excited about this, and we're trying to sort of educate as many people as possible because I think it's a new paradigm as to how we take care of patients.
That's awesome. I don't know, like it's very exciting to see these new developments because you have we talk about different ways for people to use exercise and diet, which are of course important, but sometimes it's not enough. Patients want or may need some sort of additional therapy to help with that, and to know that in the new standards of care that these medications should be evaluated for therapy regardless of A1C or metformin use. I think that's incredible. It's incredible development for people with type 2 who are at risk for cardiovascular disease.
Yes.
And um, if you have a patient who can't see you or another cardiologist, how should they be discussing this topic with their primary care physician?
Yeah, I think part of what we want to do is educate patients as much as possible to understand their own disease process and to be able to advocate for themselves. it's a challenging thing for practitioners to stay up to date with all the new medications. To be honest, I give so much credit to internists who have to stay on top of a million disease states. Each specialist is sort of trying to master their own individual area, but the internist may just not have come around to getting to all of the data that's now out on these new agents, or doesn't have as much familiarity. But as a patient, if you come back and say, I've read, that these medications are very helpful and that perhaps my outcomes, would be better in the long term. Do you think these are good for me? That could get you to the therapy that's really going to improve your risk and improve outcomes. So I think that for sure patients can learn more to push that situation, and also to make sure they've gotten cardiovascular assessment. And that could
Mhm.
be it could be through their internist who just does a extensive process, if they do,
Mhm.
of assessing their risk and deciding what they need. Or it could be for a one-time consultation with a cardiologist or preventive cardiologist to put them into like a risk scoring system to take a very detailed history of their family as to what they may be at risk for.
Yes, yes, yes. Family history is definitely important, and we definitely see that in type 2 diabetes, like the genetic risk factors. And I think I read recently that family history is also important in cardiovascular risk factors too. So definitely ask your family members who's had health issues in their family.
Yes. Yeah, it
And
takes some investigative work, but you need
yeah,
to ask
yeah,
everyone.
it's important. And what are like, so we talk about know your numbers. What are those numbers that type 2 patients should know?
So as you mentioned, the A1C is important. It's different, like some of these drugs actually improve outcomes regardless of the A1C lowering, it seems. But the A1C is still important to get under control.
Mhm.
One misconception, I think, is that patients who have prediabetes feel that, well, it's not that bad. I'm not a diabetic, so if I stay here, it'll be okay. But the reality is that prediabetes also is tied to worse outcomes.
Mm,
People with prediabetes have 2 to 3 times the risk of heart disease as the average person, which is actually quite similar to a diabetic.
right.
So it's still leaving you at risk. So getting to normal, if you can, in these various disease states is important. But again, that could be just through lifestyle, diet, exercise. Doesn't mean you need medication, but making sure to always optimize that. And if you don't get your sugars under control, you could have eye problems, you can vision problems, you can have risk of an infection in the foot that can lead to amputation, kidney problems, not just heart problems, but a lot of different things that can be improved if you get it under control.
Wow, I did not know that about prediabetes, and we started diving into prediabetes, um, and I think there are definitely people who come to a website saying like my doctor told me I'm borderline, but that I think that kind of just shows that the discussions about CVD and
Right.
prediabetes are also under discussed too. So thank you
Yeah.
for mentioning that.
Sure.
And let's chat some about women's heart health, because we know that heart disease is the number one killer in women, and I imagine that if you're a woman with diabetes, that risk is even higher. Um, are the guidelines or treatment recommendations different for women than they are men or other people? And if so, how?
That's a great question. The good thing is that when we think about risk assessment, they have taken into account a little bit more detail now,
Mhm.
so that, sex is obviously taken into account, but even race. So for an African American woman, when you plug things into a risk calculator, it will finally show that they are at higher risk for stroke, for example, and
Mhm.
that perhaps they warrant therapy even earlier
Mhm.
than a Caucasian woman. So important that people are, putting those into risk algorithms.
Right.
There's also now in the risk algorithms consideration for certain conditions that are specific to women, like adverse outcomes during pregnancy, like if you had hypertension in pregnancy, diabetes, if you had premature labor, or if you had a small for gestational weight baby,
Mhm.
those all potentially could put you at higher risk for heart disease later in your life. So it's something that is important for us to ask and then think about whether we should change treatment based on that. There's a lot, that, hormone related states, polycystic ovary disease, menopause changes, all these things that we really need to focus on more for women.
Yeah, and I'm glad that you mentioned like sort of the disparity, especially for Black women and also Hispanic women, are also at a high risk as well. Um, how I guess how do you and your colleagues try to close those disparity gaps? Like that's such a it's such a complex issue, but it's super prevalent, and obviously we see what the results are. But how do you and your colleagues try to meet those disparity challenges?
Sure. I hope that we can make even more progress, honestly, in this area. I've only started here for a couple of years in my position, but I see like the Northwell Health system is huge, and then the world is huge. So we have a lot of work to do. So I'm hoping we can make a whole lot more progress. But
Mhm.
from my standpoint, kind of similar to what we talked about earlier, I think, there's a few different areas that why do patients fail in terms of getting to guidelines in my mind is essentially what we talked about. Do they have that universal education, the baseline understanding of the disease process? Like even myself as a patient, when I understand exactly what's going on and why I'm taking a medication, I am more likely to adhere to what I'm being told. So one is the universal education that we're trying to get in different languages, in perhaps video form, in group classes, and in different mechanisms, in these great sessions that you have online for patients.
Mhm.
Then I think resources is the reality, and I think it's almost, we used to do a screening, a community screening in a homeless shelter at one point for heart disease and patients who didn't have care. But the truth is that, if patients don't have access, like it's hard to tell a patient who doesn't have access to things to eat 2 to 3 servings of vegetables a day, so providing more resources in places that they have food deserts, and getting availability, and actually really teaching how to get those, like to eat on a budget, and canned beans and chickpeas and frozen vegetables and different things, so giving them the resources, and then I think it's the motivation, truthfully, that explaining to patients that we all struggle, and that it's okay if you make some efforts and then you didn't do so well on a certain day and then you try again.
Yeah.
So I think we try to target all of those different areas to see if we can improve those disparities.
Yeah, absolutely. Like the resources is so important because it's like, yes, education is of course important as well, but knowing better doesn't necessarily translate to doing better.
Yes.
And the reality is that if you don't have money, your options are severely limited, and you're so right on like food deserts or places where the only thing they can shop is like at a convenience store, and
Yes.
there aren't options or a lot
Yeah.
of like high quality fruits and vegetables. um and it makes it harder, and there are food banks that try to like give like recipe cards or bags of groceries with like information on this is what this food does and this is how you can make a really good meal with just a few ingredients. But there's always work that needs to be done to kind of mitigate those disparities. But I think it just continues to show the need. The underserved communities really need, I think, our
They
help the
do.
most. You know?
They do. We shouldn't make any assumptions that, what's going on. You have to really ask about what the
Exactly.
reality is and stuff. I actually had a patient, more recently. I always give the example of like, you have no excuse for not walking. You just put your sneakers on and you can go outside and you can walk. And
Yep.
truthfully, one of my patients during the pandemic, at a time when there was, a lot of sort of rioting and things like that, she's like, I'm sorry, but I don't feel safe. And, in patients in general, is their neighborhood walkable? Is it
Yeah.
safe? So we can't even, my little example that everybody can go for a walk is not even true for
Right.
everybody.
Right.
Yeah.
Right.
It's
Yeah.
really,
Your environment matters. Yeah.
yeah,
Like and walkability is like if you live in an area that may not be safe, or if you live in an area that's like close to like highways and whatnot, if you don't have gyms or
right.
park or even a safe park to go to, it makes making healthy changes difficult.
Yeah,
And when you tie that to motivation, it's like what do you have to be
right,
motivated for when
right.
it's that maintaining that motivation isn't even easy because your environment isn't conducive to that.
That's exactly.
um and yeah, I think yeah, that's definitely a topic I know I can go on and on about because it's so it's really meeting the patient where they are, right?
Right, right.
And I think one thing that providers really should do is ask the patient like what's going on in your life. And
Yes.
I was sitting in a session like maybe some time ago where I said, hey, if you listen to the patient and if you ask them how they're doing, if you listen, you may actually like hear some things that may tell you, yeah, I haven't gotten my prescription because this has happened in my life. Or, yeah, my blood pressure is so high because this is what I'm eating, because this is all I have time for. This is all I can afford. And when you ask those things, that's when it's easier to kind of strategize.
Yes. I mean, we can keep giving out medicines truthfully, and it won't make a difference if there's a limiting factor, like you said. We
Right.
have to ask, and unfortunately, in healthcare, we don't ask enough.
Yeah.
Yeah,
So, finally, let's talk about some easy, practical ways that people with type 2 diabetes can work today to lower the risk of cardiovascular disease, or if they know they're at risk, they can do something to make sure that they don't experience severe complications. What are some like take-home strategies that they can use?
sure. So certainly, as we said, getting some risk assessment, learning whether they're at high risk and if they're on the right medications for prevention. And some of the drugs we talked about were related to diabetes to some extent, but there's also things like cholesterol lowering agents like statins are actually one of the main therapies by which we lower risk in diabetic patients because that will prevent plaque formation as well.
Mhm.
And I think that the last most important thing is really the lifestyle, component. Where for that, I think my recommendation generally for patients is a predominantly plant-based diet, which can be either vegan or vegetarian, but it can also be Mediterranean diet.
Mhm.
And everybody can be on a different spectrum of the diet. I think one thing is that patients often fear fruit entirely in the diabetes world, which again, we do want you to limit your sugars, but most of the time it's, patients are having a fair amount of rice and bread and chips and not eating fruit because they have sugar in them. Whereas, the reality is they're getting this processed sugar in other forms and not getting the nutrients and the benefits that those fruits actually have, and the vitamins and the antioxidants and things that improve their arteries and things like that. So I think, for each patient working with someone on diet, and it can be small changes, like you said, I think anything that's sustainable and, get you moving in the right direction in terms of, adding one vegetable to your diet or getting rid of one thing that is not good for you
Right.
is a big deal. And then really with the exercise, anything you can do in terms of getting more steps or taking the stairs somewhere that you normally wouldn't, doing some exercises in your home is such an important thing.
Yes, absolutely. And like small steps, I definitely hear you on the fruit component. We see that a lot. Can I eat something like an apple or a banana? And everyone everyone's glucose reacts differently to
Right.
fruit. But like you said, the vitamins and nutrients, the fiber that can help you lower your risks and especially help you with cholesterol management. All of those matter as well. It's really about finding, what really works for you. And that really may mean just like lowering your portion sizes. So if you know a whole banana is not going to work, maybe just little pieces throughout the day could help
Right.
you.
Right.
Um,
Yeah.
Eugenia, it was so great to speak with you. I had a great time. Thank you so much for chatting with me and chatting with our community today. This is really like an important topic, and I don't think it's discussed enough. But I'm really glad to see that the cardiologists and diabetes professionals are coming together simply because we have these new exciting drugs on the market to help people with type 2 manage CVD risk. So thank you again. And would you mind telling the people where they can learn more about you and your work?
Sure. I'm at Northwell Health, and if you go online and just Google my name, Eugenia Gianos, you'll find it pretty easily. But it sort of shows exactly what we're doing at Northwell Health. If you need an appointment, of course, we're here, and we have a great risk reduction program to help you get to those goals. And I'm really grateful to Tara and the crew for getting this information to you because she's helping us do our job truthfully, and getting the education out there and this really, really helpful information. So
Yeah.
thank you.
Thank you. Thank you so much. And to our lovely community at Beyond Type 2, we thank you for watching this conversation. For more information on heart health resources and type 2 diabetes, please go to our website, beyondtype2.org, and we'll see you next time. Bye.